session. That answered my question. And we're recording the session, and it's valuable time on an incredibly important issue for people associated with the childhood cancer journey, talking about Pharmac's review of Rule 8.1b. So I really want to thank you all for joining us. And if I could hand over to Dan to open us, please.
Kapai. Tēnā tātou I te wānau, ka wakataki I tēnei hui tō tātou waka mōme ki te atua. Nō reira, kei noi tātou. Puri te mai te tautirangi kia tina, kia wena, kia toktamana wa ora. Tina toktamana ki wea, tina toktamana ki rangi nui e tūnei ki papatono ki takoto nei. Ki tēnā ki tēnō tātou te wānei me wanaunga me ngā pininga karanga maa. Āpiti atu ki te unga māwiwi ki te ungi tamina te pauritanga. Koiara I rongoa kāria ki kirunga, tuturu waka maua kia tīnā, uie, tāi ki e. Aroha mai for my son's head popping in there.
Help me then.
Well, Tyler tēnei, this is Tyler. Back to you, Monica.
Kia ora, thank you, Dan. And I just want to start off by acknowledging the General Manager of Family Support Services who left Child Cancer Foundation about 6 months ago. She died suddenly last week and her funeral was today. So I know she would have had a very keen interest in this and have been passionate about understanding how we can all make a difference, to continue to make a difference with regards to understanding potential changes to this rule and what we as a collective can do about that. I also want to say an enormous thank you to members of the team that are here from Child Cancer Foundation. I can see Michelle there, and there may well be others. And to Dennis, our board chair, and to Stephen and Dan, who are members of our board, and Dean, who have all joined tonight, as well as some incredibly esteemed panel speakers. We've got Dr. Andy Wood, we've got Dr. Stephen Laughton, we've got Dr. Jo Cribb, and we've got Kerri Morgan, who are all going to talk to us from an informed basis around the Pharmac consultation issue and how to make good submissions. So really want to thank everybody for your time and research into this to take part in the panel tonight. We are recording, as I said, and you just heard the recording activating. So if you'd rather not show on the recording, please turn your camera off. And we are going to make the recording and the slides that Andy's going to share with us tonight available to everybody. And like I say, to all of the people that had expressed interest, about 80 people that had expressed interest in being here tonight, have asked for the material if they weren't able to make it. So I'm going to start off by introducing Dr. Andy Wood and Dr. Stephen Laughton. So Andy Wood is a Senior Research Fellow in the Department of Molecular Medicine and Pathology in the Faculty of Medical and Health Sciences here at the University of Auckland. He's also a paediatric haematologist oncologist at Auckland, Starship Blood and Cancer Centre, and he has clinical and research interests in leukemias, solid tumours, and genomics research, and is motivated by the pressing need to improve survival and quality of life for paediatric cancer patients. He is a member of the Myeloid Disease Committee and the Children's Oncology Group that conducts clinical trials with funding from the National Cancer Institute in America. So we're really fortunate, Andy, to have you join us today. And I know you've got some slides that Kerri can pass, rotate on when you give him the nod. So if I can hand over to you, Andy, and then I'll also introduce Stephen.
Monica. I've updated the slides in a few parts, so I might just share my own screen if that's going to work.
Yeah.
Okay.
Just before you start, Andy, if people have got questions, if you can put them into the chat and we'll consolidate those for asking at the end.
Okay, fantastic. Right, so thank you for the chance to speak at this forum. So as a consultant group, we're still working on our consensus response, which will be robust. And so the opinions I'm going to express are my own. And my summary opinion is that this, the reduction of drug access probably represents the most profound threat to paediatric oncology survival that I could imagine impacting our patients, our whānau, and our profession over the next 2 decades. So what is Pharmac? So the first thing to understand about Pharmac is, they're not actually the bad guys. Pharmac is both essential and they're controversial. So the government sets their budget, which is roughly speaking $1 billion a year, and that's been going up recently. Pharmac decides how to spend that money. Now, pharmaceutical companies are not always angels. They have to give their people who invest their capital the best return possible. Most drug companies will charge the price that is the maximum price the market will tolerate, and they are very aware of the emotive importance of treating life-threatening diseases. Also with drugs, across all of human health, there's a steady stream of new drugs and worthy causes. And Pharmac has a really tough job because Pharmac has to go through all the existing and new drugs and assess the costs and benefits. Then they make a priority list of how to maximize the benefit of that $1 billion a year. And the fact that Pharmac are willing to be unpopular and they have the ability to say no, that they're not going to fund something, that actually gives them a strong leverage point when negotiating prices. So Pharmac is, it's really essential to New Zealand's limited health budget. The problem is that important drugs are unfunded or funding can be very delayed. And some of the process around prioritization has not been as transparent or as fast as would be ideal. So, this photo below, we see a breast cancer advocacy group protesting. It's a true photo. It's a horrible situation that these families feel so desperate, but it's not the full story because Pharmac does a lot of good as well, even though there are certainly things for them to improve on. So what is Rule 81B? The bottom line is 81B allows our survival outcomes to be world-class. That roughly means that 5 years after diagnosis, 86% of the children we treat are alive, and that benchmarks with Australia, the UK, US, etc. Now, most of the drugs we prescribe are actually funded under the general pharmaceutical schedule that Pharmac approves. The problem arises when you want to use a drug that's not on the schedule. Now, for everything that's not child cancer, everyone else applies to Pharmac. Now, if I want to use a drug that's not for treating child cancer, I also apply to Pharmac. So child cancer is really an exception, and that's due to 81B. So for pediatric cancer drugs not on the schedule, rather than go through this quite time-consuming, tricky application process, Pharmac automatically approves the funding. What does that mean? So it means we have much better access to new drugs, and that means we can give modern care to all the kids and younger teens we treat. It means we can offer more clinical trials. Those clinical trials, in turn, give us free access to modern diagnostics and extra drugs, typically subsidized by governments in the States or Europe. And it means that the patients we treat and the families we serve can access these medicines regardless of how wealthy their parents are, which is not the case in adult oncology. So that's why our survival benchmarks, and it's one of the reasons I would argue adult cancer survival does not. And, our survival for our families is the same, regardless of how much the parents earn, where they live, and where in the country they're treated. So we don't have the postcode lottery that besets so much of the rest of the health system. Now, it's really key to understand that we can leverage the 81B investment. Why is that? Because we can offer more of these international clinical trials. These clinical trials usually test a new diagnostic and provide exciting drugs, and they do that at no charge. Typically, but not always, these clinical trials improve survival. They also establish a culture of excellence. They set standard of care. We get audited by external agencies, every few years, who go through the details of what we do, the details of how we consent, and we have to adhere to these top international standards. And that lifts our game for everything we treat, even for people not on a trial. So that ensures that we benchmark internationally. Now, if a trial requires us to prescribe a drug on one of the arms or at some part of therapy, and Pharmac isn't funding a drug that other parts of the world consider standard of care, we wouldn't be able to realize all those benefits of clinical trials. So what drugs are funded by 8.1b? Well, the fact is, most of these are not actually exceptional. Most of these are what we would consider standard of care, routine drugs that would be our first-line therapy, or if we're in the sad situation where first-line therapy is not working, we go to plan B, which use second-line therapy. So I'm not going to go through this long list, but you can see a lot of the most common diseases we treat. B, acute lymphoblastic leukemia. If you're allergic to peg asparaginase, you'll get Erwinaze, so will the T cells, so will some of the lymphomas. Some of these new exciting drugs called blinatumomab allows us to treat difficult to treat acute lymphoblastic leukemias, but far less toxic on the body. When children have had a lot of treatment and they're really broken, the magic of this drug is it's both efficacious and it's less toxic, so it doesn't beat the kids and teens down so much. There's lots of medicines on this list that we just consider absolutely routine. And the other thing is it's a diverse list with lots of subtypes of a subtype, lots of detail. Some of these drugs have also now progressed to the general funding pool, so they're on the schedule. And that's a common thing too, that these drugs over time progress. They're more likely to progress if they're important to adult oncology. What are all these drugs costing? That's actually unclear to me. In Pharmac's report, they reported the total cost of all cancer treatments. And they said for the total cost of drug treatments, they said it's 5.5 million over a recent financial year, which is just about 0.5% of their total $1 billion budget. The challenge with that is that that accounting went up to age 25 and we only treat to age 18. We asked for the raw data, we've not had it provided to us. I don't know if that 5.5 number is too high or too low. Now for 8.1b costs, the cost of that is just under 3 million. And so that's just under 0.3% of the total budget. Now, when they do these costs, there's a concept called total cost accounting, which is when you try and take the complete costs into the picture. So if you give someone a medicine and they can take it at home, not in the hospital, that saves the families time and travel, massive quality of life gains, saves the health system money. That sort of total cost accounting is actually incredibly hard to do. Pharmac doesn't do total cost accounting when appraising what drugs to use. So why did Pharmac get concerned about 8.1b and why are they concerned about it now? I can't help but wondering whether 8.1b has been on their radar and they've been waiting for the right moment to move forward. So the bottom line is modern cancer drugs, they are super expensive. Right now, pediatric cancer gets special access. No other disease, no other age group gets special access. In addition, there are new drugs coming online that are going to drive those costs up. And the argument's been made that's unfair to every other disease and age group. So Pharmac had a large external review that was published at the start of this year. And in that review, it was praised many aspects of Pharmac and robustly criticized others. And they recommended that pediatric cancer drugs are treated the same way as other pharmaceuticals in the interests of fairness. I interpret fairness differently, and I'll explain why. In addition, a patient advocate from Patient Voice Aotearoa was trying to persuade Pharmac to fund a drug called Spinraza to treat a very horrible disease called SMA, where the nerves that control breathing fail, and it's very complex to keep these children alive. And this drug Spinraza was revolutionary. The cheapest costs I know for Spinraza would be about 200,000 US a year. And you pretty much have to take Spinraza several times per year while under GA, injected into spinal fluid, and you take it for life. So it's quite a big deal. Ironically, Spinraza is now funded. And that's why I'm not sure if this review of 8.1b was going to happen anyway, or whether it's really been prompted by this external circumstance. Now, a really key issue is, will all currently used drugs be available? And to me, at least, that's very unclear. So a quote from Pharmac's document is, read it out. "We want to assure you that even if changes are implemented, all publicly funded paediatric cancer treatments that are currently used, irrespective of how they are currently funded, will continue to be available now and in the future." That kind of sounds good. Some of the sound bites on the media from the minister and the chief executive of Pharmac have sounded even more reassuring. But this is something where the devil is really in the details. There's quite a few key questions. So a key one is, sometimes we can prescribe a medicine, but Pharmac will put restrictions on. They will say, you can prescribe this medicine if only this patient has relapsed and you've tried these things X, Y, and Z. And they put on these conditions. And number one, these conditions become out of date. Number two, we often need to move very fast and in a flexible fashion. And so funding without restrictions, if that happened, would be good. But if these drugs were funded with restrictions, I personally would find that limiting and a bit disingenuous. There's another pool of public money where occasionally we send children overseas for high-cost treatments not available here. Now, what if those treatments are available here? That impacts things like CAR T therapy, other therapies. And then I do note there have been some contradictory statements. There was a Guy Espiner article, he's a very good health reporter. His comment was that Sarah Fitz said the impacts were likely to be minor. So not saying they would be, not guaranteeing they'll be the same, but she couldn't rule out a decrease in access to peds oncology drugs in the future. And that kind of matches with what I think are a series of different statements that leave a lot of wiggle room. And if they wiggled in the way of reducing their costs, I think it could really threaten the care we provide. The second big issue is compassionate access medicines. Now, we actually spend a really large amount of time as consultants trying to get drugs free of charge to the government and our families. And, sometimes the pharmaceutical companies are absolutely amazingly helpful in this. Now, some of the medicines we access under these compassionate access schemes or expanded access schemes, sometimes these are actually standard of care and we're just being cheeky and trying to save money. Sometimes they are game changers. An example that is pretty striking, it's a unicorn example, I don't think it will be repeated, but this drug, the Nutuximab, it's an antibody we treat high-risk neuroblastoma with, and we've had almost $20 million of drug provided since the start of 2016. And, I'm pretty sure we'll be over 20 million since we did that count. That's actually a lot of money, and that's been provided free of charge. There's a whole lot of complex reasons it's probably coming to an end. But because the government's never had to pay for that drug, it wouldn't fit into the criteria that Pharmac provided to say they're going to continue funding. Other drugs we've provided is this, such this drug larotrectinib, that you can treat a particular type of sarcoma. Now, when we saw the sticker price, we were blown away. $1,000 a tablet, take one tablet in the morning, one tablet at night. For 8-month treatment course, that's $500,000 worth of drug. I mean, that's hugely expensive. You are avoiding a whole lot of other costs, but it's still massive. And, that drug's been a game changer. Not only can it treat disease that chemo's not working, it can just treat it often with far less side effects. And so if 8-1B is replaced, will these compassionate access drugs be funded? I think it's essential. If some of these drugs are unfunded or there's a delay before they're funded, children and adolescents are going to come to harm. There's just no doubt about it. The second thing is, I made the comments before that a lot of people feel pediatric access, the special access, is unfair. And I can, absolutely can I see where they come from. And I'm a pediatrician and I unashamedly have a bias towards child health. But the way I'd phrase it is that the general Pharmac framework is not fit for purpose for child health funding and certainly not for child cancer drug funding. I personally believe there are extra benefits and ethical obligations of investing in child health. The obvious one is if you treat a 3-year-old with a life-threatening disease, that child, we hope, would have decades of quality of life where they can also contribute back meaningfully to society. That is different than if you're treating someone who is, has been alive many, many, many decades and is in proximity to death. I think it's different. Not everyone does. There's another philosophical concept in expenditure called fair innings. And that's the idea that you should invest more to give everyone a lifespan and quality of life that most people enjoy. And that would argue that you also invest in children. It's also important to note that I think pediatric cancers actually sit at the intersection of many disadvantages. If you imagine a Venn diagram and each part's a disadvantage, at the confluence of those would be pediatric cancers. So first of all, child health. The spend on child health is way less than adults. We don't let children and teens vote. There's parens patriae, which is in exchange for not giving children a voice, we have to be their voice, we have to be their advocates. There's an issue across all age groups called rare diseases. So when you have a type of lung cancer and you've got 6,000 people a year in the US getting it, and 12,000 in Europe, 6,000 in China, that's a massive pharmaceutical market. There's a huge amount of research academically, a huge amount of investment from drug companies. When you've got a rare disease and you've got a tiny pharmaceutical market, there's a lot less research. The research is often hard to do very well, with really high quality. It's a lot smaller financial incentive for all parties. There's often less treatment options. There's often smaller advocacy groups to try and get something funded. In cancer, there's a continual new stream of treatments in adults, motivating pharmaceutical companies to do research in kids has required an incredible amount of arm twisting, but kids are still disadvantaged. Cancer medicines are all expensive. You're talking about that. We're talking medicines that are $400,000 for dinutuximab, $500,000 for larotrectinib. Very few families can afford that at all. A few could afford it with a major sacrifice. The thing is, if those aren't publicly funded, you're essentially guaranteeing despair, and you're essentially guaranteeing, in my view, increasing inequity for Maori Pacific and groups of families who are either deprived financially or marginalized. I think it's a huge challenge. Another thing is in adult land, they have a very large chains of adult private oncology through the country. So it's a safety net in some regards, but there is no private pediatric oncology option. If you can take the tablet at home, that's fine. But if the medicine has to be infused in a hospital, we can't do that if a drug's privately funded. Shane Retty's bill may change that, but it's a real challenge. We have had some patients had drug infusions in adult care, but because adult oncologists and nurses can't resuscitate a child, they hired an anaesthetist on their hourly rate that got added to the infusion costs. So the costs were just absolutely staggering, or a family's got to go overseas. So to me, those are pretty profound disadvantages that I think there's a moral obligation to mitigate. And, the key thing is all these reasons that 81B was set up, they're still present. And in fact, I think they're even more prominent now. We have a research-based model of care. There's a really small number of children for most indications. That's a really small number of families who would have to advocate directly. A lot of the drug indications, because it's kids, they're not approved. And so when you've got this collection of very rare diseases, different subtypes, different scenarios, it totally makes rational sense to group them under one umbrella. Better drug funding reduces inequity. And so, people are worried that what happens in pediatric cancer is unfair. The reality is, because we've achieved more equitable outcomes, that makes it more fair in my view. So, as a consulting group and nursing group and, all the wider pharmacy team, all believe that it's imperative that the kids and teens receive top-class child cancer care, regardless of ethnicity, where they live, how wealthy their parents are, or where they're treated in the country. And we actually achieve that, and 81B is a threat to that. If 81B is going to be replaced, it's going to need extensive consultation. It's going to need a lot of caution to ensure we don't have gaps in drug supply. and to make sure that patients in whānau aren't really disadvantaged. And then, access to drugs in the future, if we had to join the general Pharmac queue and the general Pharmac process, really, really worries me. So that's all I have to say. Thank you.
Thank you, Andy. Lovely. Well, wow, that was so clear, so compelling, and so evidence informed. That is going to be an amazing resource for families to use in submissions, in the submission process for the consultation. And I should have said at the beginning, we wrote to Pharmac along with some other agencies asking for an extension, because the original consultation, I think, was only till the 14th of December, which was ridiculous. And they've given us till the 31st of January. And I just want to, as a colleague of Dr. Woods, introduce Dr. Stephen Laughton. So Stephen's been involved in the clinical cancer care of children since 1997, and he was the recipient of one of the very first Child Cancer Foundation health professional grants in aid in 2005, where he relocated to Memphis, Tennessee, and trained in paediatric neuro-oncology at one of the world's leading institutions, St. Jude Children's Research Hospital. In 2007, Stephen returned to New Zealand with his family to join the Starship Children's Hospital paediatric haematology oncology team. When Dr. Jane Skeen retired from Child Cancer Foundation Board, having given many, many years of service, Stephen was nominated to take on the health professional representative role. Through this role, along with his position at Starship's principal investigator for the Children's Oncology Group and his fairly recent new role as clinical lead for the National Child Cancer Network, Stephen has an incredible influence in the lives of children and families impacted by child cancer in New Zealand. So we're really fortunate to have Stephen with us tonight too. Stephen, I just want to hand over to you. Is there anything you want to add, any observations, any information, any stats, any evidence, anything that you could add that will help this group do submissions through this consultation process?
Look, thanks, Monica. Look, I think a wonderful talk, Andy. Really sort of went through and offered a great perspective on of the issues at hand, really. Look, as you say, this is a big challenge for the sector. And I think there are sort of different ways that we can go about trying to influence Pharmac and the process. And so, Andy, you spoke about the SMO-led submission. So, the two clinical services being Starship Blood and Cancer Centre and the Children's Haematology Oncology Centre in Christchurch, really providing a real clinical look at the issues and the submission. That will be a combined and united front that we offer there. But then from the National Child Cancer Network, which I'm involved in also, we will be able to speak slightly differently about some of the issues from a more, I guess, strategic and higher level perspective. And then, of course, the group on the call today can potentially say things that we as a professional body may not be able to say. In terms of some of the narrative around it. So, obviously Kerri and the team and I recognise the faces and names of a number of families that I've dealt with over a number of years. And so I acknowledge that, and I know that these stories have not always ended in the way that we would like. And so that's a challenge I acknowledge too. And as part of that journey that those people have been on has involved doing exactly what you've talked about, Andy, which is accessing drugs at enormous cost to themselves and being delivered in places that are not really fit for purpose in the private sector. And so that's a pathway we want to really try and avoid. I think it would be, I have to acknowledge, I think that Pharmac are in a difficult spot. They've got the challenge of I guess, inadequate funding to actually meet the needs of the population, which is a separate discussion. They've also got the need to respond to a Human Rights Commission complaint, if you like, that so they have to be seen to be doing something. And so I think Andy and I and the rest of the team are not so naive to think that there won't be some form of difference in the way we operate. I guess what we're trying to preserve is that it becomes something that is manageable, fit for purpose, and most importantly sort of serves the children and families well. So so I think we have to be up front about that. I don't think that it will be business as usual.
Thank you, Stephen. And we have had a few questions come in around how we get involved in the submission process. So we'll be talking about that with Jo in a minute. And somebody asking Andy, are we asking for continuation of the current 8.1b as is? And interesting just hearing Stephen's comments. Have you got anything to say on that?
Yeah, I think 8.1b's got a limited lifespan. I think even if we got it continued in the short term because it became a political issue or something, I think would re-emerge a few years down the track. And this is one of the things as a consultant group we're debating. I think my personal preference at the moment would be to have a new scheme that was fit for purpose, including budget, that was going to be robust for the next 2 decades, and so less vulnerable to a future change. You know, some of the drugs are so expensive. And I mean, anyone who runs a business or a household knows that it's hard to operate and say that you can have a cost center that's might triple its costs in 6 years' time. You know, so I think we have to be realistic about their budget management challenges. But yeah, the budget set by the government, not by Pharmac, is a really key point.
Thanks, Andy. And we'll pick that up a bit more, I'm sure, with Jo around sort of how we can be tactical on this issue to protect some gains and get some longevity. I know there's some more questions and we will come back to those, but I just want to introduce Kerri Morgan. So Kerri reached out to us when this consultation process came up. Where is Kerri? Where is she? Give me a little wave. Really appreciate it, Kerri. She's been doing a lot of work and she's very well connected and got good contacts and has been working with Kerri in the background. So Kerri is the mum to 3 young children, Jonty 7, Eliza 5 and Millie 3. In her spare time, she is a wildlife veterinarian and associate professor at Massey University's School of Veterinary Sciences. She's worked with Kerri Price here at CCF, helping pull this panel together, and has been actively researching this issue and making contact with key players. So we're really lucky to have Kerri with us on this issue and on this panel tonight. And I'd like to hand over to you, Kerri, because I believe you're going to talk from a sort of parent's perspective of your journey. So over to you.
Thanks, Monica. I've just put a presentation together as well, because just so I don't get lost. So I'll hopefully be able to share that. Yeah, you can just see all my children in the background. Can you see that okay?
Yeah.
Yeah.
Cool. So I guess I really just wanted to focus on the issue from a family perspective. I'd agree with Stephen and Andy that Pharmac aren't, you know, they're not the devil. We've got to remember they're all parents and probably grandparents, a lot of the people on there, and no one wants children to have poor outcomes, health outcomes. But I guess my understanding is they were pushed into a corner by the Human Rights Commissioner, and they really had to respond to it. So I guess it's just how they're going to respond, which is hopefully something that we can help with. Hopefully I can make this move. So I know that lots of people on this forum have their own oncology story and their own personal journey with cancer. So I thought I would just briefly talk about ours. And I've been doing a lot of thinking about how changing 8.1b could actually have changed our medical journey or change our journey in the future. So this is my son, Jonty, when he was 10 weeks old. He was diagnosed with metastatic chordoma, which is a primary bone tumour in the base of his skull. So it was pushing on his brainstem. he had tumours that were all through his liver, lung, spleen, kidney, and also in his skin. And the incidence of chordoma in adults is in people in general is 1 in a million. And from my reading, 5% of these are paediatric. And of those paediatric cases, 5% of them are in children less than 5 years old. So initially we were given no viable treatment options. We were given weeks to months with Jonty, and we fortunately were able to access imatinib, which is a tyrosine kinase inhibitor, which had been shown some promise in treatment of chordoma in adults, not in curing, well, not in like getting rid of it, but in stabilizing disease and giving people longer. Then we, based on a single case study of a child in the States who I talked to the oncologist that dealt with that child, we were able to put him onto etoposide, which is was both of those medications were oral. So we were actually able to give those to Jonty at home. And fortunately, most of the time we've spent in Starship actually hasn't been in the oncology ward. Most of it's been dealing with complications of his tumour. So he's had, as well as having 3 years of chemotherapy, he had 8 neurosurgeries to deal with the complications of his, where his tumour used to push in his brain. But he's been in remission for 5 years now, and he goes to school, he rides bike, he learned to snow ski, plays football, swims, does everything that a nearly 8-year-old would do, as well as causing lots of grief for his parents. So from our family perspective, I guess for the disease that Jonty has, mostly if you were to look in a textbook, the disease he had would be in adults, and if you were going to pick an age and gender, you would be a 60-year-old male that had this disease. And in adults, they're really resistant to chemotherapy, so the main treatment for adults is surgical removal and then followed up by radiotherapy. And adults are actually resistant to chemotherapy, so despite lots of trying different protocols over the years, nothing had previously shown any success. But in children, there was a small but growing body of evidence to show that there might be some place for chemotherapy in treating children. But for pediatric chordoma, like I'm sure a lot of cancers that a lot of families here have been dealing with, there's just simply not enough cases to enable clinical trials. For this disease, where there's a like I'm sure the same with a lot of families, you get involved and you find other cases around the world because you want to know what other treatments are available, and there just is like a really small number of cases globally for this. So that means that for these kinds of cancer or rare cancers, that chemotherapies won't be evidence-based. They won't be based on clinical trials, but rather selection of medications and therapeutic protocols will be based on single case studies. And I work in academia, and I know also that it takes a lot of time to publish a paper, and I'm sure, like most people, I've got about 15 that need to be published because people just simply don't get time to actually publish in the scientific literature, and this is where it's all available. So there is a lot of anecdotes or case studies that are sitting on desks of oncologists, and they don't know about. And also, thinking I've been watching the Chordoma Foundation, which is a group based in the US, and there's a plethora of new drugs coming online and being trialled in adults with chemotherapy. So, and some are showing some kind of successes, and there's other children that have tried different things. None of them actually, mostly there's a close to 100% mortality of this disease in children. So we're really, really lucky. But I've been thinking a lot about what would happen if 8.1b didn't exist. And in actual fact, imatinib, which is the drug that Jonty was on, well, one of the 2 drugs, that's actually now funded on schedule, if you saw Andy's list before. But I've been thinking about, what if that drug combination didn't work? What would plan B, C, D, and E have been? Would it have been something that's just, one is based on another single case study where they've had some effect? And then, what if Jonty relapses? We try not to think about that, but that's, something that, what if, in 10 years' time he relapsed, and how can we guarantee access to drugs that that aren't currently available. So Pharmac say that they're going to continue funding drugs that are available now, but what's going to be available in 5 years? Because even in the 7 years that we've been involved in cancer treatment for children, the different drugs that have been coming out have been remarkable. So you can imagine that in the next 10 years there's going to be another whole lot. And I think that, by Pharmac saying, don't worry, we're going to continue to fund the drugs that we're currently funding, I don't think that should cause us to be particularly comforted. So issues with drug access, a lot of this is things that Andy had already talked about, but I've been talking to a few families, and everybody that I've talked to didn't even know that 8.1b existed, and so don't know if their children's medications were actually funded through this section, or if they were funded through the schedule. But to be honest, I don't think we should have to know. I'm sure, like most of you families, you're faced with your child who has been diagnosed with cancer, and you're just kind of hanging on. You're trying to keep your family together. You don't actually want to have to think about those kinds of things. You want to know that you've got the best available access to the medications, and you need to obviously trust that we're able to get that. But what happens if we can't get funded through 8.1b? And firstly, like, how would we actually fund these? And there's already, give a little pages, and if you're lucky enough to own a house, maybe actually selling your house to fund a treatment that's overseas, because as Andy had said, we can't actually access non-approved pharmaceuticals because we don't have any private paediatric hospitals. And I think about the time when Jonty was a baby, and he needed a neurosurgery, which we didn't have access to in New Zealand. And I know this isn't a medication, but I think the same process was in place, really. And we needed a surgery to save his life, and we were not able to access it in New Zealand for a whole bunch of reasons. So we looked over to Australia. We found a surgeon that was willing to do it, and we were scrambling. He was really sick. We were looking at how could we get him over to Australia. My parents were going to sell their house. We were going to sell ours, because to get him on a medical plane was, $500,000 or something ridiculous like that. And then he got to the point that he was actually too sick to transport anyway. So he didn't actually, we weren't able to access it that way. Unfortunately, we ended up getting access through Starship. But I thought a lot about that, and about how we would stand by and watch, not being able to get access to a treatment that could save our child's life. Like, how would we actually live with that? So I guess, I always would have thought the worst thing would be, watching your child get cancer, but I think watching your child get cancer and then not be able to give them the appropriate treatment would be even more horrific. So I guess what can families do about this? Well, everyone that's here is getting informed about the proposal, and hats off to Child Cancer Foundation for putting this on and bringing everyone together, because it's a really important subject. And I guess and it's being Child Cancer Foundation giving the support in this way hopefully means that it's families aren't going to get panicked by it, because there's hopefully a process we can work through. I would encourage you to get online and read the consultation document. It's about 30 pages, but it is relatively easy to read. But just get informed about what the actual proposals are. There's 3 different options that they're proposing. One is keep it the same. 2 is fund all children up to the same amount, so all other diseases in children. And the other one is to get rid of 8.1b. And then we can make submissions to Pharmac. And I had a meeting with someone from Pharmac a couple of weeks ago, and he said they want submissions and they want real life stories. They don't want 15,000 of the same submission. They want to know how this is going to impact people. So I think knowing what drugs your child has access to that were funded through 8.1b would be really important to know, to be able to give a viewpoint in the submission. Thinking about how your child's oncology journey would have differed if you hadn't had access to these medications. And then what about the future for this? How, if your child's currently receiving a drug funded through 8.1b, what are what are their plan B, plan C, what if they relapsed in 10 years' time, and also thinking about how could this impact other families in the future. And I think that's me. Thank you.
Good. Thank you, Kerri. Sorry, I'm still in isolation. I've got COVID. So, Kerri, thank you. That is incredibly generous of you to share such a personal story with us. And you've put so much thought into how to use that in a powerful way and how people can think about doing submissions for this really vital issue. So hats off to you and thank you for joining us tonight and the work you've done to date to get us to this point. Really appreciate it. And our final panelist for this evening, it's my pleasure to introduce Dr. Jo Cribb. So Jo's a consultant who's had a track record of developing and executing strategy, influencing decision makers and finding solutions to complex policy and organisational challenges. She's an experienced chief exec, board director, strategist, gender and policy expert, formerly the Deputy Children's Commissioner and leader of the Commission's expert advisory group on solutions to child poverty. Jo is the director on a number of government and NGO boards. She has a doctorate in public policy that investigated the contracting relationship between governments and NGOs. So Jo is absolutely passionate about child health. She's worked with Child Cancer Foundation and other child health related charities that we're part of a coalition of. So it was an absolute natural to invite Jo tonight to help us frame, from someone who's been in the thick of it on both sides of receiving submissions and making submissions, around how some pointers and some advice for us understanding that process. So over to you, Jo.
Oh, kia ora koutou, and thank you for the opportunity to be here tonight. I did 20 years in central government agencies, being basically writing documents like this and receiving public submissions. And what I thought I would do is frame, and sorry, I have I'm bringing no sort of insight running on Pharmac or anything, but what I did is read the document through a policy lens, and I'll pick out what I think are the key issues. And I've also looked at the questions that they're asking you in your submission, and I thought I'd kind of put them in unpolicy speak, if that makes sense, and then maybe give some ideas, because I really do think anyone who's got enough time and energy to submit should, and you shouldn't see it as a daunting thing. It doesn't have to be fancy. It really is just your view. So what I thought I might do is just step through what that might look like. There's an online form. It's fairly easy to do it mechanically, but it's how can, if you are going to spend the time writing a submission, please do, how can we collectively make sure that that is impactful and your words are impactful as they could do? So when you read the policy document, I think we can pick out the key issue that Pharmac has got. We've already, I think we've already addressed that. And they put two, I think, quite key statistics in there. They would say that 93% of medicines are already funded, 7% require the 8.1B, but that 7% accounts for half of the paediatric cancer spend. So basically they're saying we've got a very small number of children that take up half of what is spent on paediatric cancer drugs. So that's directly what they're saying. And the overall cost is increasing. And implicitly they're saying, because we don't, this is me, please, this is my interpretation, we don't control that spend, it's very hard to manage it across our portfolio. And they also obviously got their other lens with the havoc they're being forced, and the issue has come through their review. Are we being equitable for other children with diseases? Are we being equitable with other people with rare disorders? Are we being equitable with young adults with cancer? They're asking that kind of question, as you would imagine, across their whole portfolio. They also are in a very, as everyone will know, the health system is in a very transitional space, if that makes sense, but a lot of those kind of key planks of the future health system, I think, are in place. and that's very strong around equity across everything, and Te Tiriti of Waitangi is very key, and you'll see there's quite a lot of analysis in the policy document about outcomes for Māori, outcomes for Pacific as well. So that's going to be quite a crucial part of the drivers of the system going forward. So these are just sort of pieces of context I would just keep through. So what they will do with your submission, I thought I would start with that. Also, there will be a team and they will receive the submissions. They will treat it like, well, normally this is what I've seen happen for 20 years, is that you treat it like research. So each one is like a survey that's come, and they will need to analyse them because there will need to be some sort of synthesis. And there will be a report. I don't know whether they'll make that public or not, but it'll definitely go to their senior management, their board, and probably the minister. So they will be looking for themes in terms of, if you're responding, what are the themes that are coming through? What are the key messages that are coming through? I'd imagine in the decision-making process, it's not only a public submission, there'll be others, experts that are brought in, there'll be advisory groups, so the Māori advisory group, all sorts of different inputs into the decision-making process, but this will be a really strong piece of it as well. So think about when you are writing your submission, that you make your points really clear, right? So no ambiguity about what you're saying. I hope they get a lot of submissions. So you've got a team of analysts sitting in a room analysing as if it's written data, and they'll be looking for trends. How many people said this? How many people said this? How many people said this? So the clearer you can be, that the more likely you are going to be counted, if that makes sense, in any kind of analysis. The real key questions they're asking you, and this is me putting them in my own words, is, and it's exactly as Kerri said, what is your story? What difference has this made? And in some ways that is building a family. One of you would have seen in the Pharmac review, the sort of criticisms perhaps about not being patient or as family-centred as they should be. So this is going to be incredibly important for them, and the whole health sector is thinking about that as well. So as Kerri said, exactly what happened, as much as you feel sharing, what happened has happened for you, what's been your experience, and what were the outcomes, I think, not only for your child, but I think you really need to say for your family and whānau as well. So what has been, and what could have been, what are the potentially, as Kerri said, what could have actually happened? And I don't think we only just talk about the medical outcomes. I think you really should talk about the stresses that this puts on your family, and all because that is becoming hopefully an incredibly more important part of decision making as well. It's not only medical, but it's that broader system as well. So do share if you feel comfortable and able. But if you can even like bullet point, these are the things, right? It's very easy then for an analyst to pick those up and put it into it. They've asked for broader observations about the sort of a number of times around system of care. I guess this is, I'm not really sure why that is, but I guess pharmaceuticals are only one part of care of a child, and they're asking for that bigger picture. If you've got some insights, but what they have asked at the end is really for help for these two key, I've called them dilemmas, or the issues they've got, which is around the equity around cancer patients and health outcomes, and the issue around this managing budgets and spend. Now, the strongest potential argument for equity, and I think Andy really touched on it, is that at the moment the outcomes are fairly equitable. There isn't necessarily postcode care. And if the drivers of the health system are to increase equity, why would you remove a key plank that was actually already creating that? So I think there's a strong line of argument around that. And the issue about managing budgets, like Andy and Stephen, I think there's probably a process solution here. There's something around how say Pharmac and the oncologists work, so that they can, that we can say Pharmac can de-risk the spend, but we can also get maximised income. So I think there's probably a solution. potentially in a response to that is that you want to be at the table. You want oncologists at the table, and you want the family voice at the table. So I potentially would rather than trying to solve their dilemma, is that you get a voice at that table to be part of what potentially is a negotiation. The alternative is that we do play, and I was talking to Monica, that we do start to play my child matters more than your child game, where nobody wins, right? So, or this person is valued more than, and that isn't a particularly sophisticated or useful necessarily response to what is going to potentially be, there is probably a solution and a way through here. And you want to be there, and you want your voices and your experiences represented at that table. So that would be kind of maybe a way through those questions where they're asking for help, is, well, put us at the table, put the foundation at the table, put the parents' experiences at the table, and let's work through this let's work through how this can be. The equity issue is, why would you unpick something that is already delivering what they're actually trying to build in the rest of the health system? I think there's a really strong argument there from a policy perspective. So clear points, evidence if possible, if that makes sense. So and that doesn't, by that I don't mean research evidence, if that makes sense. So if you're making a statement and you can back it up, there is always, if you can, like, bullet point it, analysts will just take that, does it make sense, and analyze it quickly. And if you have got really clear views or recommendations, make them really clear. That means that your submission then has the best chance of being picked up, synthesized and analysed as part of the, hopefully, a very large number, and helping to inform the future policy going forward. But I'm happy to take any questions about that. You don't need to use fancy words. It does not have to be long, but your views is your experience, your family's experience, your children's experience is incredibly important to this process. And I really, if you've got the time to do that, please do. Talking with Monica as well, maybe there's some wording or some, no, I'm not suggesting that, but if there's some themes, so let's say linking this back to the outcomes of various reviews, if there's some things that can make it easier to answer some of those, what I've called dilemma questions, I know Monica and the team are happy to share that. But again, your stories are really critical to this as well. Monica, back to you, but happy to take any questions as well.
Thank you, Jo. Some real practical, helpful pointers there, and confidence around everyone can do this really effectively. And the more people who mobilise, saying some key consistent themes, the more likely it is to get picked up, analysed and processed, and maybe some positive action happening. If 100 of us went saying 100 different things,
yes,
it went out to Pharmac. Oh, nobody agreed. There was no consistency. We didn't hear a strong message from the sector and from parents. So that's where the sort of next sort of stage of this may come in. So really important that we do that. We were, Jo, myself and Kerri, talking earlier today that it might be really helpful for those of you that don't mind doing it, that could share your submissions with us, because that can give some helpful advocacy to us as an organisation. So just if you feel comfortable sharing that, and there may be some really great points that some of you make that we can then share out with everybody else to go, hey, make sure you put this, if you feel comfortable putting this in your submission. We are, like I say, the deadline is the 31st of January. We can go back and ask for another one. I don't know how successful we will be on that, but we could go back asking for that after this forum, because we also know there's an awful lot of interested people who couldn't make it tonight that will also, I am sure, want to do submissions. And myself and Kerri are in communication with Stephen and Andy going forwards around sort of sharing intel and information. So I think that presentation from Andy is going to be key for all of us doing submissions, so that we can pull evidence-based information and understanding of Pharmac into the submission processes, because like Andy was saying, it's not fit for purpose. All of the political indications that we've heard is that the minister doesn't want this on his hands. He doesn't want this, issue on his hands. But Pharmac need a different way of handling it, to be seen as equitable, given the review, given the issue and the ruling of the Human Rights Commission. So what can we come up with that will protect outcomes, world-class outcomes for childhood paediatric oncology, of which therapeutics is a key issue, we know, and we've all heard it tonight, but in a way that we will get some traction with Pharmac. So the other thing we may want to think about with the submissions is, we would like an opportunity to talk with Pharmac, and if they heard that enough times from a body sort of related to the organisation, we may again get some traction around that. Kerri and I had a very positive meeting with the head of policy and his team just before they put the consultation document out. So CCF were on the radar, so we want to use that sensibly as well. So if I can hand over to you, Kerri, because I know some brilliant questions have been coming through. If you could pick those up, please, and ask panel members maybe to answer those. And then we will do a wrap up.
Sure. I've just been responding to things in the comments. Just going through the questions, I guess they break down into sort of two questions, two types of questions, and that is one about the clinical type aspects. And I think somebody made a comment that they thought the new and or better drug requirements for our children in the future was one of the aspects that was most important to them. So I think that kind of is a nice little summary to start them off. But the first question was really around what proportion of patients receive drugs under 8.1b, and what is the trajectory if the rule were to remain. And I think we heard about 7% of the total spend, but that doesn't necessarily mean it's 7% of the patients. So Andy or Stephen, over to you.
Sorry, it's in the document. It's 7% of cases and 50% of the spend. That's in the Pharmac right. document. Yeah.
Did Andy or...
I was going to answer. So we'd really like to see their raw data so we can go through that ourselves. We've asked for it in the past and we'll continue to ask for it. So Kerri brought up a really key thing, which is, if you're a parent and your child's got cancer and we've just had that conversation with you, or the treatment's not going well, and we're having that conversation with you, for a parent to have to worry about the mechanism of drug funding or availability is quite a challenging situation at so many levels. Number one, the thing I was going to say is, if you're a parent with a child with cancer, your child's either received something under 8.1b, or your oncologist has been thinking about it if plan A doesn't work, because when we're giving your child plan A, we're always thinking about plan B, C, D. Like, we're always planning the moves ahead, because sometimes it requires a lot of preparation. So even if it hasn't impacted your child directly, one of the hard things about child cancer is there's a chance of relapse, or that treatment causes a second cancer. So if your child's had cancer, there's still a chance that 8.1b could be relevant to your child and your family. So I sort of see 8.1b as broadly relevant, and it's also broadly relevant now and for the future.
So the next question was around clinical trials, and what do you think the process or the future would look like in terms of clinical trials without 8.1b.
Stephen's not piping up, so I'll jump in. I think it's going to limit our access. There's some trials we'll still be able to run, but if we can't provide a medicine that's considered standard of care, it'll decrease our access. So, you know, I haven't gone through all our trials and worked out a percent of our current trials, but, you know, acute lymphoblastic leukemia is the commonest drug the commonest disease we treat. And if you get, you know, an essential medicine is asparaginase, and if you're allergic to the first preparation, we give you another preparation. And that second preparation, in case of allergy, is funded by 8.1b. Now that's required to treat any child with acute lymphoblastic leukemia, whether it's a B or a T, or lymphoblastic lymphoma. And so, you know, you've immediately got a third of all cases where you need that drug up your sleeve, or you can't open any clinical trial. And most of our enrollments on COG trials are for acute lymphoblastic leukemias. So, you know, while we think that would be grandfathered through, you know, as I said, there's uncertainty, but we don't know what the key medications are going to be in 5 years or 10 years or 15 years. Is one of the key issues.
To pick up on that, that Erwinaze story. Erwinaze is not a new drug. It's been around for a long time, and the fact that it is still hasn't made it onto the schedule is just another illustration of how unfit for purpose the current processes around Pharmac getting drugs funded. So it is nothing. It's a wonderful option to have available to us, but there's nothing inherently exciting or novel about it that it would be characterized as a new drug.
Okay, thanks for that. So somebody asked the question around the process of getting on the pharmaceutical schedule, and is it likely to be equitable between adults and paediatrics?
Great question. Look, I think simplistically, probably not. I think we as a, you know, if we're going to say that we are doing very well in the paediatric setting, to have the same access, or, you know, and we account for about 0.5% of cancer in the country. Like, we have 100, actually it's a lot less than that. There's 150 new children a year diagnosed with cancer in New Zealand, and about 25,000 adults. And so we are a small component, and to have the equivalent amount of funding available in the adult sector with adult size people and dosing is a challenge for a small country like us. So I think equity right across the age range is, well, it would be wonderful. I suspect it's not a reality. And in fact, it's arguably even a challenge for us to even address the AYA group, the adolescent young adult group, and actually having the same capacity to fund drugs for those that happen to be over the age of 15, for example, where the paediatric sort of cutoff sort of nominally lies. And so that's a challenge that we're sort of working through as we submit. But certainly going further into the adult space is even more disparity.
Thanks for that, Stephen. The next question is really around what are we asking for? A continuation of 8.1b, or what would a new system look like in terms of what, I guess, both you and Andy think would be workable?
I can start off, Andy. I mean, I guess from a clinical perspective, we want to be able to respond in a timely fashion. And so to have a newly diagnosed child and talking to their parents and their whānau, and then be sort of days to weeks before we know whether we're going to get access to a medication that we actually want to start that day or the next, is a problem. And so timeliness to access has to be a really critical part of a process. We've started to put some ideas around how we might make a process more visible to the agency, because I think that's one of the challenges that Pharmac has, is that there are these paediatric oncologists out there that are prescribing drugs that there's no oversight of. And I think we as a group actually take that quite seriously and actually are quite rigorous in how we go about what we do, but that's not visible to Pharmac. And so I think part of the process that we're developing is to make that a little bit more transparent to them. And I think we have been good stewards of the funds that are there, but that's not obvious to them. So timeliness is a big thing. Andy, I don't know if you want to add to that.
Yes, I think the asks in my mind go, number one, 8.1b has to remain until there's something else that's workable and that we actually understand and we've actually had a chance to risk assess it, because I do see large risks if they transition out of it too fast. Number two, I think Pharmac and the ministry, and this is where it gets tricky. I think the framework for how this country looks at child well-being and child health is not consistently and rigorously conceived at a philosophical, ethical, policy level where you can go, oh, here's our principles for kids, how do we apply them? I don't think that's happened. So I think within our space, that's why I tried to illustrate why I personally don't think the framework, there's the comment that it's what happens in pediatric cancer is unfair. And my counter argument, well, it's produced a fair outcome. So I don't think something bad produces something good. So, in my mind, the framework has to be reconsidered. I think that's a long-term mission. It might be a year's piece of work. Pharmac might not want to wait that long. Like Stephen, I don't think 8.1b is going to remain. But I think there needs to be a budgetary process and ring fencing. And I think there needs to be enhancement for pediatrics and pediatric cancer for the reasons I outlined before. You can say, look, it's unfair to other groups, but I fundamentally think you should equity up and bring other groups up, not equity down, to bring us down to where we get outcomes that are behind other countries and go, look, that's a success now because we've brought them down too. That makes no sense to me at a practical or ethical level. But there's a lot of times when the devil in the detail for our arguments needs to be thought through as well. As a consultant group, we are not going to try and solve all Pharmac's problems for all child health or for adolescents and young people beyond our age range, because it's beyond scope of the submission. And there's other consultation we would have to do around that we don't have the ability to do or time to do in this time frame. So we are going to be quite focused, but Pharmac's just funded drugs for CF and Spinraza for this neurological SMA. Those diseases are lifelong treatments, pretty much, at similar price points to what we're talking about for temporary durations. But while kids can have a temporary duration of treatment, they're getting other treatments too, and the cancer can come back. So it's not, comparing against other children's incredibly where we don't want to be. But the time course and expense of treatments, they do matter. And I think a key part of this is not just what's the framework that Pharmac's using. A key part of this is Pharmac would love to fund all these drugs. The people at Pharmac really understand the impacts, I think. Am I critical of Pharmac? Sometimes, yes, but I think the people at Pharmac would have a deep understanding of the benefits to patient families if they had more budget. I really do. So I think it's two-pronged. I don't just think this is about Pharmac. I think this needs to be about the government's total budget for pharmaceutical expenditure and how they manage child health. I think we can't let the government get off the hook by letting Pharmac be the bad cop, in my opinion.
Yeah, I agree with that, Andy. Absolutely.
So somebody just commented on that we need to be so careful about getting rid of something that is currently achieving equity of outcome, unlike so many other areas, and sort of agreed with what you were both saying 100%. So just feed that back. The next set of questions were really around, I guess, that public policy and political approach. And I would preface this first question by saying we have written to the Minister of Health requesting a meeting in early February, late January, early February. We've yet to receive a response, but this question to the panel is, would it be helpful to undertake political action, visiting local politicians, writing to the Minister of Health, etc.? Jo, you might like to take that one.
Yeah, I can answer that. If again, I have no inside running. I wish I had a secret little bird that told me the answers, but I would be very surprised if a minister or Pharmac makes a decision this side of an election. Why would you? Given the environment that we're in. So it might be completely wrong, because this actually is a Pharmac, potentially a Pharmac decision, but and they're an independent, they're a Crown entity in their own right, but so that probably means there is time, because the solution is probably more nuanced than yes, no, right? It is probably a negotiated, stepped out, thoughtful, hopefully thoughtful solution. And so I would completely be angling that parents and that whānau and children's voices are in this mix, right? So yes, if people have got time and energy and they want to go and see their local MP, what it will do is educate their MP, because they probably have no idea about the system. Whether an MP can actually change anything, they can't. It's going to be between the Minister of Health and Pharmac. Cabinet ministers probably can, if they can lean on their colleagues. So if you've got the energy, it probably won't do any harm, but I'm not sure it's the most effective mechanism right at the moment. I would put your time and energy into a submission, and yeah, really pushing that whānau voice is right, is centre in whatever happens next, right? And organise yourself just in case the worst happens, right? So that you are ready if a decision does come, that you're absolutely organised. So those structures look like. I think you've got some ideas and some, so that you're ready to go if you have to. I'm just not quite sure what seeing your local MP would do quite now. If that makes sense.
Yeah. Can I just briefly add, thank you, Jo. I mean, this document obviously is concerning, but really, if we look at it, it's an invitation for the sector to inform Pharmac of the sort of state of play, if you like, so that they understand what the issues are before they make a decision. So this is not a decision document that will follow. I'm not minimising it and saying it's not a concern, but I think there will be opportunity down the track where Pharmac
absolutely
a little bit clearer with their sort of next document that we will be able to respond to. And I guess the other comment I would make, I'm conscious of time, but is that you as families can do things that we can't. And I know that it looks really daunting to look at 16 questions. I don't believe you have to answer all 16 questions. And I think that many of those questions really relate to the sort of the health professionals and the sort of the system, if you like, to respond to. And so I guess I'm just encouraging you to not be put off by that. And
absolutely.
If you tell your story, then that's wonderful.
Tell your story and ask that your views are factored into the process going forward. Would be, I think, the key messages.
One of the remarkable things that we always talk about as a healthcare team is, when we talk to families about trials, we always say, this trial may or may not benefit your child, but it will absolutely help us in the future with future families, because we have a better idea of what to do or not do. And I think it's a big ask, because I've never, I'm not in the shoes of a parent, thank God. But I do think we need to embrace would ask families to try and embrace that same approach of that generous service, despite being in the horrendous situations that you've faced. Because, you know, I think that's actually key. I think the parent voice in explaining the parameters is really important, because, you know, as I said, we don't think this document's going to be the thing that reframes how the government manages child health as a whole, but it can be a building block in a small way. You know, and I think of people hearing family expressions, and you know, you guys can say things we can't.
And on that, oh, sorry, Kerri. I was just going to offer if anyone would like any help with writing submissions, because it might be something that's a bit daunting, and I'm very happy to help from a family point of view.
Thank you. The next question was around PIORA at the Act, which was passed in 2002 in relation to equity, and this should this be in our story? I think that if you can weave that through, it's helpful, but I would note that if you look at the Act, it does specifically provide an out for Pharmac based on doing things within their budget. So it's something to be a little bit cautious about, or to comment specifically about that in relation to their budget. Jo, did you have any?
Sorry, just in terms of that, there are some specific planks, I guess, in terms of the health reforms, and some key pieces that do help navigate this. So that was what I was suggesting, Monica, even just providing some of the skeleton of those, if that makes sense. So what you're doing is you're referencing your story and your point back to what basically the government has already promised. They've made some promises in their Act, and you can reference back to them. Again, it's just that another little bit of evidence that'll make that bullet point stronger, but that's probably quite easy, something CCF could do, couldn't it, Monica?
Kerri and I spoke about that further today, Jo. So looking at the key bits of legislation and policy from the government and the Cancer Control Agency, and, you know, and just pulling those out and sending them around to you all so that you can put them into your submissions. And I just saw actually someone asking Kerri whether you'd be able to do a bit of a model response. Maybe you can, you know, we can work with you, with Kerri, to do that, and then we can get that out, and then people can put in, you know, where it's your personal story and where there's specifics that you want to put. Because I think, Andy, what you said earlier, keep it, you know, we've got to keep something that's workable, and we've got to sort of risk assess any change and any transition. And I think that's got to be done in consultation with paediatric oncologists. That there's this broader issue of Pharmac and the Ministry of Health, that Pharmac are actually chronically underfunded. That is all part of the problem here, and that needs to be a statement in the submission process. The issue around ring fencing, and the fact that we go equity up, not equity down. All boats rise on a rising tide. We do not want them sinking. So,
well, the legislation has promised that, so that I would tag it back, right?
So there you go.
Yeah.
So exactly. So wherever we can tag it back to the government's own intentions, the better. And I think that was a really powerful set of key messages that we can extrapolate a bit, Kerri, tomorrow. I say Kerri, and it covers both of you, which is brilliant. And some of this key government policy too. And like Kerri said, we've written, and Jim Bolt has offered to do some of the sort of ministerial government lobbying. So we are working on that in the background as well.
So just the next question, and I just saw one pop up that asked about Stephen and Andy, what would be the top 5 areas that you can't talk about that would be helpful to hear from families? And just one of the earlier questions was, is there an argument to be made around the ageing population sucking ever more funding from children's health? So I thought there was a link there.
Well, I guess in terms of top 5 things, I guess we as a group don't want to be fighting or in combat with other paediatric groups, you know, like that have their own battles to get funding for their own interests. And so, and I'm not suggesting that you do, but there are certain things that we want to sort of stay in our lane and focus on the issue at hand. I think having personal stories is something that we clearly don't as a group have, and I guess you can be a little bit more candid about things than we can, where we probably want to be focused on sort of processes and data and more sort of hard and factual things within the limitations of what they are. And I think if I could just pick up on what Kerri shared about the rarity of her situation, one of the challenges in a group like Pharmac and making decisions about drugs is that there is a scarcity of data. And so if they apply the same lens that they do for looking at adult data, where, you know, Andy said there's 6,000 here and 12,000 in another study, there isn't that rigor. And so we're at risk of being cast aside because of a lack of evidence, which will never be there. And so decisions have to be made in a much more pragmatic way in pediatrics, and so that's a challenge that we need to address. Could I just pick up? I just see the comment that Dan made, and Janelle also agreed with it, just about Māori and sort of equity, and you know, we heard before about the Give a Little pages, and if we reflect on the successful Give a Little pages, they tend to be not necessarily representative of those that have the greatest need or requirements, and this is being highly generalizable and stereotypical, but I think we know what I'm saying is that those that have the nous and the connections and the ability to put together a narrative and a story do very well, and those that don't have those resources available don't. And so that again causes greater inequity. So I think that's a really important. We don't want to get into a Give a Little way of delivering healthcare.
I couldn't agree more. I think we're very concerned about the impact on Maori and Pacific. You know, we had an experience a few years ago when a drug company providing us drug for free was suddenly going to stop, and families were trying to work out how they might have to pay 400 grand for some medicines. And, you know, some families can just not, they're struggling to cope day to day, let alone put their family on the front page of a newspaper or on a website for fundraising. And if, you know, families have already come to us and they've been marginalized or they've suffered in some way, and you're asking them to sort of do something insane, it's just horrendously unfair. I think a really big gap in our response so far is Maori and Pacific perspectives. I think we need to do a much better job of working out how to articulate that and having the Maori voice and Pacific voice. I think one of the key things listening to Kerri's story is, you know, there's just such an authenticity, and, you know, you listen to it, you feel slightly tearful inside. That's a voice that as a health professional, you know, we just can't generate that. I just think that your own authentic story, you don't need to make it up. You just need to say what happened to you. And I think it's just going to be incredibly powerful.
The Pharmac were doing, and I was going to follow that up a little bit. They did oral submissions, so like video submissions for something else. So so I had a meeting with the chair of Pharmac a few weeks ago, and he said that was incredibly, from the panel's perspective, really hard for them to, like, it's one thing seeing it written down, it's another thing actually having people speaking, and the emotion that can come through your voice. And so that would be something, if we're able to do that. I think that would be really powerful. And the other thing which I think would be worth, from a clinician perspective, is the impact on you guys as clinicians must be horrific as well. You'd have to make choices around whether you actually tell people that there is another medication that they could get, but it's going to cost them $200,000, and you know that you can't, that family, can't even make ends meet each week, let alone give them that. And will the options that are offered to families be restricted, because you've got that ethical dilemma? And I imagine I can't imagine Andy, you say you can't imagine being a family with a child with cancer. I can't imagine being an oncologist who has to deliver this news continually, but delivering it and saying, well, there is a drug that could save your child, but we can't give it to you. The impact, the mental health impact on oncologists, I'd imagine you'll get compassion fatigue and burnout a lot greater than you already do. So I think that that's not just us families that are dealing with that, the emotional issues of it as well.
So to the first point, the Health and Disability Commission has already ruled that you have to let a family know about treatments, even if you think they can't afford it. You can't make assumptions. And, broadly speaking, part of informed consent is to tell a family what the alternatives are. And, as hard as that is, and the practical realities, I think that's true. And, we are very concerned about the workforce implications if we're having to do an extra 5 hours of paperwork a week to access drugs. It's been a tricky few years. And, we're concerned about, you can make a process that sounds accessible, and then you can make the forms to access it horrendous. And it becomes a sort of what I'd call a virtual barrier. It looks like there's no barrier, but there is a barrier. And we know adult colleagues who are exhausted that have struggled to find the time, and then you don't do a submission that's as good as you want, and you don't feel good about it. But it's it's just a big challenge. And there's if the adult oncologists want to get Herceptin funded, there's a whole bunch of them. There's an army of them that can start writing in. And it goes back to that, why why peds cancers have to stick together as a whole and not let there be a divide and conquer into separate diseases, situations, tumor streams, where because you've got so few voices a year anyway, we can't let that be reduced down into silos.
Thanks for that. I'm just conscious of the time, but there are a few things just to follow up. And Dennis actually answered this on behalf of CCEF, and that was, who can provide that family voice at the table? Is that something that CCEF sees within their role? And I think that's true. Yes, we can, and we want to be a broker for that. We had a conversation with Pharmac earlier in the year, and one of the things that came across quite strongly was they didn't necessarily know how to engage with families, and they didn't know how to engage with Māori and Pacifica families. And so that is something that we would like to see happening, and like to see be able to make that happen on behalf of all of the families that we engage with. And then there's just a last question from Nick, which was, can our kids make submissions as well? And the answer to that is
yes.
Anybody can. And in fact, the kids' submissions may well be more powerful in some respects. So,
and even if you've got, say you've got your own parents who've watched you, maybe invite them to say the impact on on the wider family as well. Like this is a insight you have that should be factored into decision making, right? It has to be there at the table. Yeah.
So we'll end that discussion there. I think based on the discussion that we have had, there's more. There's perhaps more opportunity to have another question and answer session maybe in the new year. And if you I think if you'd like to be part of a parents reference group, a Māori and Pacific reference group, if you can email me, that would be great, so we can keep you informed and engaged, and we will also be looking at sharing our submission early in the new year. But for now, I'll hand over to Monica.
Oh, look, thank you. And I just want to say, I was just thinking about this forum and how educational it has been, how inclusive it has been. We've got policy, we've got clinicians, we've got families, we've got CCF, and how thoughtful everybody's contributions have been. And therefore, for me, how powerful it has been. And, you know, this is the beginning of working in this way and being as effective as we can as agents with all these different hats on, but coming together to agree how we can tactically and strategically tackle these incredibly important issues. So Kerri and I are going to be doing a bit more scheming, and we'll be communicating with you all. We will be sending out the wonderful slides. Kerri, actually, can we have yours as well? Because that would be super helpful, along with Andy's, as well as the recording from today, to all of you and all of the people that expressed interest in being here tonight, but couldn't be. We will be sharing our submission, and like Kerri said, we will be more than happy to host and coordinate another forum or anything that is helpful for this group. And I'm going to hand over to Dan in a minute, but I do want to thank Dan for he always opens and closes and holds us beautifully in these forums. Thank you to Kerri Price from CCF for making this happen. To our amazing panelists, we could not have had better people than Andy, Stephen, Kerri and Jo. Really well-rounded, just amazing. And, you know, to all of you parents for coming tonight, giving up your time, being prepared to, you know, give more of your stories. And I think that takes a lot of courage, actually, you know, when you've been through what you've gone through, and to be prepared to, you know, to try and protect these outcomes for families that are yet to go through the service. I just think that's so admirable. And to the CCF staff and board and Whānau Connect leads that have all been here tonight too, I just really want to thank you all. The collective is way more powerful than the individual. So can I hand over to you, Dan, please, to close us?
Kia ora, Monica, and also to I just want to mihi to all of the panelists. Before this, I was thinking, right, we've got to grab our taiaha and do the land march against Pharmac, but I actually really acknowledge you gave a balanced view on that, and the fact that it's not so much Pharmac, it's actually there's a bigger picture here, and also the fact that I can get involved. I didn't think that I could, and I also didn't know how, but this has been really good for me as a parent, for Joshi, and just from something that I think I can really get involved in now. So thank you. This karakia, if we're okay to do this, this talks, it's an old one, and it talks about the tumultuous and dark times that all of us go through, but it also talks at the end about the piercing ray of light that comes when there's a new dawn. So if it's okay, we leave with a positive perspective of what, you know, there's a positive future for us, I believe, here. It's not doom and gloom. So ka waka kapi tēnei hui tō tātou waka maumete ki te atua, nō reira kei nui tātou. Waka takata au ki te uru, waka takata au ki te tonga, kia mā kina ki uta, kia mā taratara ki tai, e ia ki anatia takura, e tio e uka e au TA mauri ora. Kia ora tātou. Thank you.
Kia ora. Thank you, Dan. Thank you, everybody.